Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Standard Medical Notes. Today we will discuss about heart failure. So heart failure can be divided into acute heart failure and chronic heart failure. So we will divide it into acute and chronic. First we will discuss about acute heart failure, then about chronic heart failure, step by step. Okay. So let's begin with the name of Allah. First of all, what's the definition and classification of acute heart failure? Heart failure is a clinical syndrome caused by structural or functional cardiac abnormalities. Structural or functional cardiac abnormalities. Structural means any LV hypertrophy, valvular disease. These are all structural. Functional means some arrhythmia. Okay, some arrhythmia. That is functional abnormality. Okay, so it is caused by structural or functional cardiac abnormalities that leads to inadequate cardiac output. So there is decreased cardiac symptoms of hypoperfusion and elevated intracardiac pressures. So there is symptoms of congestion. Either it can be systemic congestion or pulmonary congestion. So what is the diagnostic criteria for that? So it requires two things. Diagnostic criteria requires two things. First, the patient should have symptoms and signs. What are the symptoms? Dyspnea, breathlessness, orthopnea, breathlessness on lying down, pedal edema, bilateral. Okay, bilateral edema, not unilateral, bilateral edema. Easy fatigability. Okay, and if you examine the neck, elevated JVP. Then examining the chest, you will have first point, that is bilateral basal fine crackles you will have. These are the symptoms and signs. And of having these signs, you should have objective evidence. Okay, either one of these two. This or you are having, no. Number one, BNP and NT-proBNP should be raised. How much it should be raised? So to exclude cardiac failure, remember an arbitrary, more commonly NT-proBNP is used. NT-proBNP is used. So regardless of age, consideration of the age, 300, okay, less than 300 picogram per ml excludes cardiac failure. Less than 300 picogram, or in terms of age, you can take in terms of age NT-proBNP levels less than 15 years of age. So less than 50 years of age, a value of less than 300 will exclude cardiac failure less than 50 years of age. Okay, and more than 50 years of age, a value of less than 900 nanogram per ml will exclude. Okay, this, and more than 75 years of age, a value of less than 1800 picogram per ml will exclude. So remember this age cutouts. Okay, 300, 900 and 1800. That means if the value is more than 300 or 900, 1800, you should further evaluate the patient. That is the meaning. Okay, so objective evidence, you should have either elevated natriuretic peptides or imaging evidence or hemodynamic proof of injections. That is done by 2D echo. Okay, 2D echo evidence. So these are the two conditions to say the patient has heart failure. Now, American Heart Association describes this heart failure as a continuum. It is not a single thing. Slowly it will develop. Okay, how that association describes? So first the person will have risk factors. First the person will have risk factors. Okay, so that is known as stage A. Then the person will develop some structural heart disease, but there will be no symptoms. Structural heart disease, for example, low left ventricular ejection fraction. Normally the left ventricular ejection fraction is more than 60%, normal 60 to 80%. Okay, if it is less than 50, it is 40 to 50. If it is 40 to 50, it is known as borderline ejection fraction, and if it is less than 40, it is reduced ejection fraction. Okay, just remember these things. Okay, so if first one is having these factors like hypertension, coronary artery disease, diabetes mellitus, but no structural heart disease or symptoms. Stage B is structural heart disease is present, like low level LVF and LVH, but there is no symptoms. Stage C is symptomatic heart failure. Okay, you will have structural heart disease also and current or prior symptoms. Okay, and stage D is advanced heart failure. The symptoms are refractory despite maximum medical therapy, and that patient requires advanced interventions like mechanical cardiovascular support, MCS, or cardiac transplantation, heart transplantation, or palliative care on medications. So these are the 4 classes. This is important because this is continuum. This is important because each will have different treatment. In this, you will try to reduce the control the risk factors. In this, you will give medications which reduce the left ventricular hypertrophy and increase the ejection fraction. In this, you will give diuretics along with symptom treatment with treatment for stage B. You will give diuretics to control the symptoms. And in advanced failure, nothing will work. You will have to plan for some advanced intervention. That's why this stages are important. Okay. So another classification is also important for treatment. So what is that classification? One is HF-REF, that is nothing but reduced ejection fraction. One is HF-MREF, mildly reduced ejection fraction. HF-PEF, preserved ejection fraction, or HF-IMPEF, improved ejection fraction. REF is nothing but less than 40%. Mildly reduced ejection fraction, Oxford gives this as borderline, HF-BEF. HF-BEF, sorry. HF-BEF, like this. Borderline ejection. Oxford describes this as borderline ejection fraction, but this what do you call McMaster gives as mildly reduced ejection fraction. Both are same. The ejection fraction is 40 to 50%. Okay, that is borderline. More than 50 is preserved ejection fraction, that is PEF. And improved is when you give some treatment and from the baseline, so suppose if the ejection fraction is less than 40%, and it improves by more than equal to 10 points, bringing the value more than 40%. So at least 10 points the ejection fraction should increase, so and the value should go above 40%. So that is known as improved ejection fraction. So these are the 4 phenotypes of heart failure depending upon ejection fraction. Now see, these are some causes depending upon the phenotypes of HF-REF. So HF-BEF and HF-PEF, you will have the causes. Just see here, the most common cause of HF-REF are ischemic heart disease, you can see, and dilated cardiomyopathy. So dilated cardiomyopathy and ischemic heart disease are the commonest causes of HF-REF. Okay, and other things you see, commonest causes of HF-PEF are HF-PEF. I'm saying sorry. So it is hypertension, 3 marks. These marks are nothing but strength of association, and atrial fibrillation, okay, and aortic stenosis. So these 3 are commonest causes of HF-PEF: hypertension, atrial fibrillation, aortic stenosis. So just remember these things. Okay, and borderline ejection fraction, all of them play a role. Ischemic heart disease, dilated cardiomyopathy, hypertension, AF, aortic stenosis, mitral regurgitation. So these 2 valvular diseases are most common causes of heart failure: aortic stenosis and mitral regurgitation. So let's move on forwards. So other classification, these are the 2 very important classification because treatment depends upon them. Okay, see, these are some other classification just to remember. Anatomic classification: left-sided heart failure, left heart, left atrium, left ventricle, whether it's left-sided or right-sided, right atrium, right ventricular, biventricular, both sides of the heart are failing. So this is anatomic classification. Hemodynamic classification, you can take high output cardiac failure versus low output heart failure. High output heart failure and low output heart failure. What does that mean? High output heart failure means that the cardiac output is normal, but still it is not meeting the metabolic demands of the body. That's why and there will be vasodilation. In this case. There will be vasodilation. Cardiac output will be high, but it does not meet the metabolic demands of the body for some reasons. And low output heart failure is nothing but which we have learned: HF-REF, HF-BEF, and these are low output heart failure. Okay. Now coming to the pathophysiology and etiology. Key mechanisms. So this is a vicious cycle. So first some event takes place, some index event takes place. Okay, some index event takes place. What is that index event? Either it can be MI, ischemia, most commonest, or pressure or volume overload, cardiomyopathy, or some toxicity. So that will lead to neurohormonal activation. So these are compensatory to maintain the cardiac output, but in long term they are detrimental. Okay, so what are those? Those are activation of the sympathetic nervous system and activation of the renin, angiotensin, aldosterone system. This is important because to understand the therapy of cardiac failure. Okay, so in the short term they will try to compensate for the cardiac output, but in the long term they have uh, detrimental effects on the heart. What is the detrimental effect? That is nothing but ventricular remodeling. What is that? So the myocyte biology will change. There is fibrosis in the heart. There is chamber dilatation or hypertrophy. So again, these changes in the heart will worsen the heart function, and this cycle will repeat. They will worsen the heart function. Again, cardiac failure will cardiac output will decrease, and again that will activate the sympathetic nervous system and Rais system. Again, that will cause ventricular remodeling. Again, ventricular remodeling will decrease the cardiac output, like that. So this cycle we need to break. For example, like in arrhythmias, no, there are circuits. So we need to break the cycle of that circuit to control the arrhythmia. Similarly, we need to break this cycle in order to have a better outcome. So what will be the systemic effects then? Systemic effects. So because of reduced heart failure, there will be decreased renal blood flow that causes acute renal injury. There will be gut congestion that causes inflammation and abdominal organ dysfunction. These are systemic effects. So it affects abdomen and kidney commonly. Now we will see these are the mechanisms of Harrison. Okay, Harrison and Davidson. You can see here. So whenever there is decreased, whenever there is decreased heart failure, whenever there is heart failure, there will be decreased cardiac output, there will be decreased BP. So baroreceptor will sense that, and they will send the signals which are sent. The signals which are sent. This is not coming actually. The signals which are, because of this baroreceptor, they will send the signals. There will be apparent decreased inhibitory signals. So what will happen? There will be increased sympathetic nervous system activity, and there will be secretion of vasopressin from the brain, from the pituitary, vasopressin secretion. Both of these, what they will cause? They will cause vasoconstriction. So to increase the BP, both of these will cause vasoconstriction. But this is detrimental also. So this vasoconstriction, what it will do? It will decrease the blood supply to the kidney as well as to the limbs. Okay. So decreased blood supply to the kidneys, what will cause? So there will be decreased apparent arteriolar pressure. So the JG apparatus will sense. JG apparatus will sense that. So sense decreased sodium. It will send the decreased sodium, that will cause secretion of renin. Okay, and that renin will convert the angiotensinogen 1 to 2, and again this angiotensinogen 2 will cause again vasoconstriction. That will causes the increased to maintain the BP. Okay, and one more important point is this increased sympathetic nervous system activity will cause tachycardia. Okay, so this tachycardia, again this will increase the demand supply mismatch. It will generate demand supply mismatch. So that's how the pathophysiology works. Okay, so that will become a cycle now. See this cycle. So what will happen in that cycle? So there is heart failure. That's why there is reduced cardiac output. So because of reduced cardiac output, there will be the baroreceptor reflex will be activated, and that will cause increased sympathetic nervous system activation and secretion of vasopressin. Both of these will cause decreased blood supply to the kidney. That will cause Rais system to activate. Okay, so all of these, what they will do? They will cause vasoconstriction again to maintain the BP, and they will cause sodium and water retention. Angiotensin 2 will cause aldosterone will be there. No, right? Angiotensin, aldosterone. Angiotensin 2. This angiotensin 2, apart from vasoconstriction, it will cause increased aldosterone. What this aldosterone will do? It will maintain the sodium and decrease the potassium. Okay. So there will be one side vasoconstriction, second side the sodium and water retention. So vasoconstriction will cause increased afterload. Okay, that will increase the blood pressure and cardiac work, and increased this sodium and water retention will cause increased intravascular volume. That will again cause increased blood pressure and cardiac work. So because of this increased blood pressure and cardiac work, there will be cardiac remodeling. There will be myocyte loss. There will be fibrosis. There will be hypertrophy. This cardiac remodeling, again, that will cause heart failure, and heart failure will again activate this neurohormonal system, and again this cycle will repeat. Okay, that's about the pathophysiology of heart failure. Now, why does this reduce the cardiac output? cardiac output. See here, this diagram shows how the cardiac output reduces with heart failure. So normally when there is increased end diastolic volume, there is stretching of the fibers of cardiac muscle fibers. Okay, so according to Starling's law, the more the stretching, more will be the contractility of the heart. So this is the normal graph which is there. But when there is cardiac failure, this graph will become steeper. This graph will become steeper. What that means? This is mild cardiac failure, this is moderate cardiac failure, and this is severe cardiac failure. That means for suppose 50 ml of blood, the ventricles were contracting some 20 kilopascals, means pressure they were generating in normal condition. This is for some example. Now they will, on 50 ml, they will generate just some 50 kilopascals of pressure. Okay, and in moderate case 50 ml will generate 10 kilopascal, and in severe, that is in D, 50 ml will generate just only 5 kilopascal. So that's how there is worsening of cardiac contractility. So in order to bring this graph again to backside, we should reduce the afterload and increase the contractility. Okay, see here. So this is normal A, B, mild, moderate, C, severe heart failure. Ventricular performance is related to the degree of myocardial stretching. An increase in preload, that is nothing but end diastolic volume, end diastolic pressure, filling pressure, or atrial pressure, will therefore enhance function. However, overstretching causes marked deterioration. In heart failure, the curve moves to the right and becomes flatter. An increase in myocardial contractility or reduction in afterload will shift the curve upwards to the left. So what is our goal in the therapy of heart failure? Our goal is to decrease the afterload, increase the myocardial contractility, and one more, remember, prevent the ventricular remodeling. Remodeling should be prevented. That is our goal. So what are the common causes of heart failure then? We have discussed in that Oxford table already. HFRER most common is ischemia and cardiomyopathy. HFpEF is most common hypertension, atrial fibrillation, and mitral stenosis. Okay, mitral stenosis. Hypertension is the most common among all these. Others you can take obesity, aging, coronary artery disease. This we have not learned. No, high output heart failure. See, so there is anemia. There is now the cardiac output is there, but due to decreased hemoglobin, oxygen supply to the tissues will be less. So what will happen? Tissues will go on to anaerobic metabolism. So this anaerobic metabolism will generate some metabolites like lactate, pyruvate. Okay, lactate and pyruvate. These metabolites will cause vasodilation. And because of anaerobic metabolism, one thing which is going to happen is there is decreased ATP production. Now, this vasodilation will cause increased pulse pressure. And this decreased ATP will cause decreased contractility of heart. That decreased contractility will lead to pulmonary edema or peripheral edema, or it can be peripheral edema. That's how in high output heart failure, this is the mechanism. Okay, in thyrotoxicosis, cardiac output is normal, hemoglobin is normal, but the metabolic demand of the in general of the cells of the body is increased because of increased thyroid hormone. So demand is more, but supply is fixed. So that causes heart failure. AV shunts again. Okay, shunts, they will mix up the oxygenated with deoxygenated blood. Again, same anaerobic metabolism. Okay, beriberi. One important cause is beriberi. What is beriberi? Beriberi is nothing but thiamine deficiency. Again, this thiamine deficiency what will cause? So it is an important part of Krebs cycle. So Krebs cycle due to thiamine deficiency is due to carbohydrate metabolism. So thiamine is required for carbohydrate metabolism. So when there is decreased glucose due to thiamine deficiency, due to carbohydrate, again the cells will shift onto anaerobic pathway. And the same thing will happen as I have discussed in anemia. So that's about high output cardiovascular. Remember anemia, thyrotoxicosis, and beriberi. Beriberi in the sense wet beriberi. There are two types of beriberi. No, dry beriberi, that is neurologic, that will develop neurologic symptoms, neuropathic symptoms. Wet beriberi will develop cardiac failure. Okay. So what are the common precipitants we will discuss in this chart, which is coming below? Harrison's chart. Just remember this here. Common precipitants: acute coronary syndrome, arrhythmias, not taking the medications properly, or some infection, some upper respiratory tract infection. So patient can develop heart failure, hypertension, increased BP, renal failure. Renal failure will exacerbate the heart failure. Okay. So these are the precipitants of heart failure. Now, see, this is the selected causes of heart failure. So heart failure with reduced ejection, as we know, this is coronary artery disease and cardiomyopathy, the most common cause. Okay, heart preservation, hypertension, atrial fibrillation, and valvular heart disease are most common. In that, hypertension the commonest cause. So valvular heart disease, these two are the commonest. High output, thyrotoxicosis, anemia, okay, cirrhosis, liver disease, okay, beriberi. So these are the common or shunts. These are the causes of heart failure. Just remember the first flow chart of common phenotypes causing heart failure. What are the common causes? I will just revise. Commonest causes I will revise. That is, number one is coronary artery disease. Number two is cardiomyopathy. Cardiomyopathy. Number three, hypertension. Number four, atrial fibrillation, some arrhythmias. Number five, mitral stenosis. And number six, one more is aortic stenosis, not it's aortic stenosis and mitral regurgitation. These are the commonest causes of heart failure. Just remember. Okay. Now moving forwards. So you need to differentiate whether it is left heart failure here, whether it is left heart failure or it is right heart failure or some congenital heart disease. You can remember this in this manner also: pulmonary hypertension and pericardial disease. This is a means very easy manner to remember the causes of heart failure. 5 categories you can divide. What are the 5 categories? Increased left atrial pressure, increased right atrial pressure, congenital heart disease, pulmonary heart hypertension, pericardial tension. So left atrial pressure increases. Left atrial pressure. So 30 minutes already it is. In left atrial pressure, either it can be impaired left ventricular contraction or relaxation, okay, or it can be some mitral valve disease. That's why that causes increased left atrial pressure. Contraction may be due to ischemia or some cardiomyopathy. Relaxation can be due to left ventricular hypertrophy, as we see in hypertension, or hypertrophic cardiomyopathy, okay, or amyloidosis in some autoimmune disorders or multiple myeloma. You can have this amyloidosis. And the third one is mitral valve disease. So left ventricular contraction is impaired, left ventricular relaxation is impaired, or some mitral valve disease. Okay. Now raised right atrial pressure, right heart failure, that can be due to chronic left heart failure. So chronic left heart failure eventually causes right heart failure, or that is the commonest cause. Left heart failure causes right heart failure. It can be due to pulmonary hypertension, or it can be due to ischemia to the right ventricle, ischemic heart disease, pulmonary hypertension and ischemic heart disease, or some tricuspid valvular disease. Often it is tricuspid regurgitation due to dilated right ventricle. Okay, tricuspid valve disease. Then right ventricular cardiomyopathy. So what are the causes? So what first cause is left ventricular failure. Okay, pulmonary hypertension. Okay, ischemic heart disease. Okay, tricuspid valve disease. Commonly due to tricuspid regurgitation, that is due to dilated right ventricle, or right ventricular cardiomyopathy. Okay. And congenital heart disease, left to right shunts, for example, AST and VST. patent ductus arteriosus, all of these are left to right shunts. Okay, that is a congenital heart disease. Okay, and pulmonary hypertension can be due to again left ventricular failure, or some lung disease, chronic lung like COPD, asthma, okay, or some thromboembolic disease, thromboembolism, LVF, or lung disease, or thromboembolism. Pericardial disease, that is, for example, constrictive pericarditis. So now, like this, we can remember left atrial pressure, left ventricular contraction, relaxation is impaired, or mitral valve disease. Right atrial pressure, left ventricular failure, pulmonary hypertension, ischemic heart disease, tricuspid valve disease, right ventricular cardiomyopathy. Just imagine the structures of that. Okay, congenital heart disease, left to right shunts, pulmonary hypertension, left ventricular left heart failure, cor pulmonale, thromboembolic disease, cor pulmonale thromboembolic disease. Okay, pericardial disease. So remember this 5 key: increased left atrial pressure, increased right atrial pressure, or some congenital heart disease, or pulmonary hypertension, or pericardial disease. It's 5 broadly classified causes of heart failure. So this is one box to remember easily the precipitating factors in heart failure. Okay. So you can remember it as a patient related, provider related, meaning doctor, heart failure related, other disease states. Patient related, it can be commonly you can take either due to excess fluid or sodium intake. Patient is not taking the medications properly, or the patient is an alcoholic and he took a lot of alcohol. Okay. So most among this is non-adherence to medications. Provider related, provider related, so doctor can use some medications which cause salt or water retention. Okay, for example, NSAIDs. Use of medications that has negative inotropic properties, for example, calcium channel blockers, or unrecognized congestion and inadequate. The dose of the diuretics is not proper. So mainly the drugs which are given by the doctor are not proper. Heart failure related are hypertension is not controlled, ischemia, infarction, or this is structural, this is functional, thromboembolism. Okay, other are infection, important, remove this one, or renal failure, or hepatic failure, or hyperthyroidism, or anemia. So 2 things we have added here: renal failure and hepatic failure are also precipitants. So remember like this: patient, provider, heart failure related, other disease states. Okay, coming to the features of clinical features of cardiac failure. Okay, so you can divide it as symptoms of congestion, symptoms of low output. Okay, these are symptoms. So left side symptoms will be dyspnea, that can be exertional orthopnea, and paroxysmal nocturnal dyspnea, PND. What is paroxysmal nocturnal dyspnea? I have explained this in the topic of breathlessness. Okay, so cough with pink frothy sputum, patient will explain pink frothy sputum. Okay, these are the left side symptoms, mainly because there is pulmonary congestion. So right sided symptoms, systemic congestion. So edema of the ankle, sacral, or anasarca, ascites, hepatomegaly, right upper quadrant pain. Okay, loss of appetite, anorexia, early satiety. These are all features of systemic congestion. Low output, so easy fatigability, weakness, confusion, oliguria due to decreased supply to the kidney, cool extremities due to decreased supply to the extremities. Okay, so what are the physical findings now? That's about the symptoms which patients complains of. Physical findings are, first you will check the vitals. There will be tachycardia, tachypnea. Okay, Chine-Stokes respiration, that is irregular rhythm of respiration. Okay, hypotension in advanced, remember this hypotension important. Hypotension, if it is not due to, actually hypotension in cardiac failure occurs when there is MI due to, it also occurs in inferior MI, and also in right ventricular MI, Okay, so and one more is extension MI also. So these 3 can be the features of, so these 3, in all these 3 you will see hypotension with heart failure, So this is not dangerous, you can treat, this is not dangerous, but extensive MI in advanced cases will present with hypotension. So heart failure with hypotension is not a good thing, it is a very bad thing which is happening in patients. What are the exception for that? Inferior MI and right ventricular MI, they will present with heart failure with hypotension. But if these are not there, then the hypotension is a very bad sign. vitals, tachycardia, and you check the respiration. All JVP will be elevated. Okay, and lungs will hear bilateral crackles with wheezing. Okay, heart, the cardiac impulse will be displaced. Cardiac impulse. There will be triple murmur, S3 gallop. Triple murmur you will hear. Triple murmur. Triple murmur. Okay, and murmurs of functional mitral regurgitation and tricuspid regurgitation. So these are nothing but pansystolic murmur. These are functional murmur. There is no as such organic abnormality in the mitral or tricuspid because of congestion. No, there is congestion in the heart also. That's why there is functional mitral regurgitation that causes pansystolic murmur. You will have pansystolic murmur. Okay, abdomen. This is abdominal signs. Okay, these two abdominal signs and signs in the extremity, nothing but pitting edema and hepatomegaly and ascites. These are very common in biventricular failure or right ventricular failure, right heart failure. Okay, see here, these are two images which show the clinical features of left heart failure and right heart failure. See, in the right heart failure there is prominent hepatomegaly. Okay, ascites you will have, pitting edema you will have very much. So these signs are differentiating, means these are the signs of the right ventricular failure. Okay, but that much of pitting edema you will not see in the limbs in left ventricular failure. Okay, but pulmonary signs will be more in left ventricular failure. Pulmonary signs will be more. What are the pulmonary signs? So pulmonary edema will be there. You can see pleural effusion. You can see cardiomegaly. Okay, in chest X-ray, cardiomegaly. So these are the things you see. So this is NYHA classification for knowing the severity. So class 1 is no limitation, and class 2 is slight limitation, and class 3 is marked limitation, and class 4 symptoms are rest. So there is no limitation in class 1. There are some symptoms in class 2, and there is marked symptom in class 3. The patient have to take rest in order to. So patient will take rest and he will do work, and again he has to take rest for the symptoms. Again he will do. Here he will, even if he will manage, he will manage. Okay, in class 2, but in class 3 he has to take rest, and in class 4 he will be symptomatic at rest also, or in symptomatic at rest also. Okay, that is to know the severity. So let us know the investigations of diagnosis and investigations of heart failure now. So what are the important diagnosis investigation? First you will take history, then physical examination will do. You will important ECG, chest X-ray, chest X-ray. Okay, ECG and chest X-ray. In labs, troponins are important. Troponins and NT-proBNP. These two are important in labs, and other things are also there. LFT, RFT, electrolytes. Okay, electrolytes, TFT. So all these things are there. In these two, this is important. Okay, and 2D echo. So these are the diagnostic workup. Now, so you need to differentiate the pulmonary edema, whether this is cardiogenic edema or non-cardiogenic edema. Now, once you have differentiated cardiogenic or non-cardiogenic, and you have found that it is cardiogenic edema, then in cardiogenic edema you should find whether it is predominantly due to right ventricular failure, as we have seen in the cases now, due to left atrial pressure or increased right atrial pressure, or due to congenital heart disease, or due to pulmonary hypertension. Okay, pulmonary hypertension. One more thing was there. Okay, so these 5 things you should note when we have found that it is due to cardiogenic edema. Now first you should differentiate from other causes of edema. What are the other causes of edema? What are the other causes of edema? So first one is cardiac failure. So other causes can be hypoalbuminemia due to nephrotic syndrome, liver disease, or protein losing enteropathy. This is important. So this is important to differentiate. Okay. Second, you should differentiate from drugs causing fluid retention. So these are very commonly used for drugs for hypertension. So amlodipine, calcium channel blockers, non-dihydropyridine calcium channel blockers. Okay, they also cause pedal edema. So NSAIDs will also cause edema because sodium retention. Okay, so these two, this hypoalbuminemia and drugs, these are the 2 most important things you should differentiate in cases when you are considering that it is heart failure. Okay, but in hypoalbuminemia, remember the edema is often widespread and affects arms and face also. That's how you can differentiate. And in venous insufficiency, when you are considering, commonly it affects one limb. It can affect both limbs also, but commonly it affects one limb. Okay, that's how we differentiate. And chronic lymphatic obstruction also, this also affects commonly this affects one limb. And there is something called as idiopathic edema of idiopathic generalized edema, which is commonly seen in women during the menstrual cycle. Okay, just you should differentiate. Remember the important things which you should differentiate. They are this one: hypoalbuminemia. How do you differentiate this? Often widespread phenomenon. Then drugs. Okay, this will cause bilateral. Okay, unilateral is venous insufficiency and chronic lymphatic obstruction. Now, so initial differentiation between cardiogenic and non-cardiogenic pulmonary edema. So this is another chart from by science and by investigations you can differentiate between. So extremities will usually be cold in cardiogenic edema, and usually will be warm in non-cardiogenic. Gallop you will hear in cardiogenic edema, but gallop will usually absent in non-cardiogenic edema. This is science. So skin and gallop are two important differentiating features between cardiogenic and non-cardiogenic edema. Okay. Then ECG you will have some features, but this will be normal in non-cardiogenic edema. X-ray you can have hilar pulmonary venous congestion and edema, and initially peripheral venous congestion and then edema. Okay, so in X-ray mainly you can see some pleural effusion here. Okay, and pulmonary plethora you can see. Troponins may be increased here, but troponins are normal here. That's how you can differentiate from signs. These are the two signs, and these are investigations: ECG, X-ray, and troponins. By these, you can differentiate between cardiogenic and non-cardiogenic edema. These are the two different boxes to rule out cardiogenic and non-cardiogenic edema. So, key investigations: NT-proBNP. To rule in and or to rule out. To rule out, see the levels: less than 50 years, less than 300, it is ruled out. 50 to 75 years, it should be less than 450 to 900. That means less than 450, if the value is there, then in patients above 50 years, it is ruled out. In patients with, who are more than 75 years, it should be less than 1800. If it is less than 800, then heart failure due to cardiac cause is ruled out. Cardiogenic pulmonary edema is ruled out. Okay, that is that's how you differentiate. Okay, ECG never normal in heart failure. Remember this point: ECG is never normal in heart failure. Never normal. Look for signs of ischemia. Look for signs of arrhythmia. Commonly atrial fibrillation. Look for signs of AF, ischemia, AF. Left bundle branch block. Remember Williams. Okay, Williams is the mnemonic for no left bundle branch block. Williams. So there will be M pattern like this in V6 and V5, and also in 1 AVL. So left bundle branch block and left ventricular hypertrophy. Left ventricular hypertrophy. What will happen? Left ventricular. Remember the voltage criteria. So V1, R wave in V1 plus R wave in V2. If you calculate, that should be more than 35 mm. Okay, that is left ventricular hypertrophy. Sorry, S wave in V1 and R wave in V2. If S wave in V1 and R wave in V2 is more than 35 mm, then that is left ventricular hypertrophy. Okay. Chest X-ray, you can see cardiomegaly, pulmonary congestion. Okay, early B lines. Okay, pleural effusions you can see. Echocardiography is the cornerstone of you should do in every patient. Okay, assess the LV and RV function, assess the walls, pressures, etiology can know. So what are the blood tests you do? You see CBC, renal function tests, electrolytes, LFTs, hyponatremia, troponins, thyroid function tests. These are the blood tests you should do. Cardiac MRI for tissue characterization, whether there is any fibrosis in the tissue, whether there is infiltration, whether there is inflammation of cardiac tissue. So commonly you do this one. These are the basic investigations which you do in patients of heart failure. Now, okay, till now we have learned about up to diagnosis and investigations. In the next video, we will learn about how to approach a case of acute heart failure and what is the treatment we will give in the acute stage and in the chronic stage for the heart failure. Okay, we will meet in the next video. Thank you for your listening.